Hello, my name is Karen Goodman, and I'm a radiation oncologist at the Icahn School of Medicine at Mount Sinai, and I specialize in gastrointestinal cancers, including pancreatic cancer. Pancreatic cancer is a cancer that arises in the pancreas, which is a small organ in your abdomen that makes some of the enzymes that help you break down foods and also manage your sugar levels, like insulin. So, pancreas cancer is often difficult to diagnose because the signs and symptoms of pancreatic cancer are often very difficult to identify. There are things like weight loss and some abdominal discomfort. And so they're very nonspecific, and it can take many months before a diagnosis is made, which is why oftentimes when we diagnose pancreas cancer, it is much more advanced and it has spread elsewhere. Some of the other symptoms can be developing diabetes, having issues with obstruction of the bile ducts coming out of the liver, which can then cause something called jaundice. And what you would see is that your eyes might turn a little yellow and your skin turns yellow, and sometimes it changes the color of the urine and the stool. So pancreatic cancer is generally diagnosed when a patient presents with some of these symptoms and undergoes a CAT scan that identifies the tumor in the pancreas. Other times, patients come in with some discoloration of their skin with the jaundice, and they undergo an endoscopy, and they're found to have a blockage of the bile ducts. Other times, patients come in with pain somewhere elsewhere in their body, and sometimes there's already tumor that has spread elsewhere in the body and could be causing pain, pushing on some of the nerves, or it could be elsewhere in the bones. Pancreatic cancer is treated generally with a combination of multiple different modalities of therapy, including chemotherapy, radiation therapy, and surgery. For patients with early stage pancreas cancer, they will often have evaluation by a surgeon. And if their tumor is felt to be resectable, they can either go directly to surgery and then receive chemotherapy afterwards, or more and more, we're giving chemotherapy up front prior to surgery, and then patients go to surgery after 3 to 4 months of chemotherapy. For patients that have tumors that are more advanced but have not metastasized and do not have stage 4 disease, we often use a combination of upfront chemotherapy, hopefully to shrink the tumor down and to treat the whole body at the same time. And then we use radiation therapy to help potentially shrink the tumor down in order to allow for surgery. And in the cases where the tumor has shrunk enough to be able to undergo surgery, those patients can go on to surgery. Other times, if the tumor hasn't shrunk enough, they continue on chemotherapy. The reason why that tumors are often not resectable, or they're not able to undergo surgery, is because these tumors are very close to some of the big blood vessels in the abdomen. And if those blood vessels are surrounded by tumor, we can't remove those blood vessels. So the tumor is not amenable to surgical resection. So the Center of Excellence for Pancreatic Cancer Multidisciplinary Team is a group of radiation oncologists, surgeons, medical oncologists, radiologists, and pathologists who get together on a regular basis to evaluate patients with pancreas cancer. We also have a large team of social workers, palliative care physicians, nutritionists, genetic counselors, who are all available to see our patients should they need that evaluation. And this is really an amazing way for patients to be seen in a one-time setting by a large team who are all specialized in pancreas cancer to be evaluated and determine a treatment plan that is tailored to the needs of that patient. So the reason that we think this is a great way to address patients with pancreas cancer is because this is such a complex disease and really requires input from many different specialties. So we think that for patients with pancreas cancer, being able to see everybody together to be able to make a decision about the right plan of action is much better than going to multiple different doctors at different times, each with their own separate specialty and opinion. And in this multidisciplinary setting, everybody makes the decision together, and we can really maximize everybody's expertise and their ability to sequence the therapy, make sure we're giving treatment in the appropriate fashion, and even consider clinical trials for our patients. So this is a great opportunity for us to determine if a patient is a candidate for a clinical trial and offer that to our patients. It also allows us to get treatment started more quickly if everybody's there together, rather than having sequential visits with different doctors. If they come on one day, see everybody together, get all the right imaging and staging information together, then we can move forward quickly. We have a nurse practitioner who is a coordinator for the committee, for the meeting, and gets all the information together. So we have all of the data that we need to make our decisions, and we'll even order scans or labs that are necessary prior to our meeting. Our patients will usually come in the morning, be seen by the nurse practitioner or one of our surgical or medical oncology fellows for history and physical. They'll undergo a CT scan if needed. All of their lab work is done. And then during the noon hour, all of the physicians get together and review the information for the patients. And then in the afternoon, the doctors go in to see the patients together and discuss the treatment plan. We also have nutritionists and social workers there. And we also have the ability to quickly refer our patients for palliative care. We're having our genetics counselors involved and getting genetic testing on all of our patients. So this is really the most comprehensive and patient-centric way to provide care for patients with pancreas cancer.